So it doesn't have any evidence of squaring of the shoulder with subluxation of the shoulder joint. Deltoid muscle well preserved. But if you look at the bicep, there's a gross biceps wasting is quite clearly seen. The lateral wall of muscles is also wasted. His hand is practically listless on that side, all right? So this is the observation. And the next thing, immediately move his turn the patient around and you look at the back. So if you look at the back, the trapezius is well preserved, right? Sometimes the trapezius can be affected in a high trauma plexus injury due to direct trauma to the spinal accessory nerve. Okay. Though the spinal accessory nerve is not part of the plexus. But you can obviously see the supraspinatus and infraspinatus fossa is wasted. Again, seeing that here, you can see this is all part of the wasting, but the deltoid is still got fairly well preserved. And then you look here and look whether there's any gross, obvious rhomboid wasting. So there's no rhomboid wasting. The serratus anterior seems fairly, but if you look carefully here, it's wasted. So if you look here, I can't see the medial border of the scapula. Here I can see quite clearly. So there may be some. Okay, so that's the from the back. Okay, come back to the front. Okay, so immediately, so your objective of brachial plexus examination is to distill. That means, is it a root lesion, is it a trunk lesion, is it a division, and is it a cord? So you need to assess it from that way. And then the second part of the assessment is to assess from cephalocaudal, right? So which level here and which level this way, so 5, 6, 7, 8. So doing a dermatome and a myotome assessment, so that's important. So looking, we finished the inspectory findings, so we straight away go and look. So in your assessment also, you want to include the possible reconstructive strategies. So you're thinking about nerve transfer, you need to then assess the function of those muscles. So the first thing is, I would do the trapezius first. So shrug your shoulders up. So that's good. And push up again. So that's grade 5. So trapezius is intact if I want to do a spinal accessory to suprascapular. So the second thing to do is you want to see how much of abduction you have. Move this shoulder out this way. Yeah. So it's got pretty good deltoid function, but I don't think there's a trapezius that is compensating with the deltoid. But now I want to see whether the supraspinatus is working. Though we have seen the wasted, the arm down again. So in the same position, you may want to test for this. So when you push your hand, turn back again that way. The serratus anterior. So put the wall again there. You can put his hand against the wall and push. No winging to the scapula. So serratus anterior flex. Rhomboid's pretty good, right? So in fact, there's a rhomboid hypertrophy here because of compensation. So he's trying to stabilize the shoulder to get his, so because of the weak supraspinatus, the rotator come back again. So the serratus and the rhomboid. So C5, C6 roots are good, right? So he's got no flexors. Now we want to look at his wrist. So the way to go down from here. Okay, so first thing I want to do is I need to see my donors for my reconstruction. So the two important donors for me is the FCR, the FCU. So can you flex your? So it's FCU as hard as you can. So you can see here, FCU is strong, palmaris is strong, FCR is strong. So it's grade 5. So I got no problem taking this to out. I got my palmaris to help with wrist flexion, and it's got finger flexion. So I don't have to worry about wrist flexion. So I know my two donors are there. Okay. Both. So this one you cannot bend. So what you can do is turn your arm outwards. So there is a supraspinatus. So external rotation is a supraspinatus. Today I can see a little supraspinatus working. So if that sort of thing, that means there is a neuroplexural injury to the suprascapular nerve, not a complete injury. So I don't have to worry about shoulder abduction. Okay. Even if it was, the deltoid is significant enough for me to leave this shoulder, so I don't need to reanimate the shoulder. Then the thing is to test for bicep. So I want to see you test with gravity neutralized. So flex your elbow, bend your elbow, so there's nothing. At the same time, I want to see you put the finger there to see whether there's a flicker of movement or not. Because if it's grade 1, there may be a flicker of movement, so there's none. You're in this position, you might as well test the triceps. Push your hand, so its triceps is grade 5. You've got a strong triceps, got a strong deltoid, so I don't need to consider anything for shoulder abduction, so triceps is pretty good, right? So just now you should mention the scars that we're not going to inspect. So I've completed the thing. So he therefore doesn't have elbow flexion. Test for motor power outcome. So he's got grade 5, right? So he's got good plexus, so I know that the lower plexus is intact. So actually, that's all for the motor. Pan plexus injury. Then I want to see his respiration. Take a deep breath. So both diaphragm moves. So I can.
This by the
Yeah. Yes. So you can do even augment that with a chest X-ray.
Yes.
So this tells me that both diaphragm are working. So the phrenic is intact. That's another contemplation if I wanted to use that. So the next thing is to do 7, 8, T1, right? So it's quick light touch. I'm talking about exam oriented, right? You don't have to do cotton wool and all this is going to take you time because you want to move on, get a quick assessment, and then move on to the reconstructive possibilities. So that's you score your full marks. So that completes the assessment. So I've assessed. I know this is probably an upper trunk lesion. With that is because the biceps has not fired yet. It still could be a neuropraxia because its recovery has occurred in the supraspinatus, maybe not yet reached the biceps. So what we therefore then you say is now I need to ascertain because it's 3 months now. How long is it? Yeah. So 3 months down, from there to there, maybe it hasn't recovered. So you need to augment that with electrodiagnosis. So simplistically, I mean, I can't, I'm not good at EMGs, but what do you want to look for? You want to look for fibrillation potential. So you put the needle into the biceps and the fibrillation potential, then you know that's denervated muscle. So why are we not doing plexoplexal reconstruction? I mean, just look at it and try and graft it. You can, but it's unpredictable results. So because the more proximal you try to reconstruct it, you may lose fibers down the sensory component and may not be targeted to this. So the objectives here for him is to provide pure targeted. The other thing I forgot to do is to do a posterior cord assessment. So move your wrist up. No, so he's got wrist drop, finger drop, thumb drop. So he's got a radial nerve palsy. But this is complicated because he has a humeral sharp fracture with a radial nerve palsy. So looking at the plexus in itself, your objective now is to provide elbow flexion. So he's a purely upper plexus lesion, upper trunk, and he has got biceps paralysis, right? So